Okay, everybody, it's 1 o'clock, and just to let you all know that the recording has started, so I think we'll make a start. So I'd just like to begin by saying welcome, everybody, to this Lunch and Learn, today's session. I'd like to particularly welcome Siobhan Jones, who is the Headache Nurse Consultant for North Cumbria Integrated Care. Siobhan will be delivering our session today and talking about managing primary headache, diagnosis to treatment, and it's a whistle-stop tour. The next slide just tells you a little overview. The Lunch and Learn sessions are a space for health and care staff to come together to share any experiences, learn something new, focus on quality improvement, and of course be signposted to further resources and further networks. And the next slide, thanks, Siobhan. So just some protocols for you. As I said, we are recording, and we just ask you to keep your webcams off unless you get invited to speak during the session or after. So webcams off, and please make sure that you're on mute just to avoid any distractions. You can use the chat option to post any questions or any contributions. Please listen with respect and, of course, teach this forward. Share this knowledge and learning with lots of other people and your wider colleagues. The recordings will be placed on the CLIC YouTube channel alongside the whole playlist of the previous Lunch and Learns for you to share. So without further ado, I'll just hand over to Siobhan.
Oh, thank you for the lovely introduction, Tracy. So good afternoon and welcome to this Lunch and Learn. So this is a map for today, or should I say for the next 20 or so minutes. And when we say whistle stop tour, it certainly is a whistle stop tour for a good overview of primary headache management and treatment. So I'm going to try and encapsulate as much information as I can for you. But to cover all headache would take quite a few sessions. But we will start off with some objectives. Then I'll move on to the introduction, move swiftly on to primary headaches, treatments and management, and then I'll signpost you to some resources and guidelines. So the objectives for this session, I would say, is to, I think first and foremost, appropriately recognise before ever getting to the diagnosis of primary headaches. And then from then on, investigations, treatment and manage. We're also going to just very briefly touch on secondary headaches and then move on to some information, guidance, pathways and etc. So you may be wondering why I've put this up first, but you know, migraine headache has affected people for many years, as you can see here. Hippocrates himself, I would think, probably suffered with migraine. And if there's any of you in the audience who suffers with migraine, you will sort of empathise with the violent pain, maybe around the right temples, head, neck, and obviously the awful side of associated symptom of vomiting. So that was his description all them many years ago. So, you know, treatments weren't around then. So I just like putting that up because even back then, they probably, I bet it was quite frightening actually. So it's very historical. So a few facts. So around 10 million, astoundingly, 10 million people aged 15 to 69 in the UK suffer with migraine. Globally, it is estimated that the prevalence among adults of current headache disorder, they're symptomatic at least once a year. It's about 50%. Headache on 15 or more days every month affects 1.7 to 4% of the world's adult population. Goes without saying, the NHS spends around 150 million per year. That's probably more now, treating migraines, and 250 million on actual care. And then, you know, this leads to further costs to the wider economy, with even higher costs. 4.4 billion a year is lost to 3 million migraine-related sick days. So primary headache disorders, primary in that they are not caused by other diseases. So they're a brain pain disorder themselves. And it's essentially a malfunctioning of the brain network, which can lead to pain and other symptoms. So different primary headache disorders do present with different symptoms. as well. And of course, unfortunately, they do respond to different treatments, so it's not a case of one size fits all. Secondary headaches, of course, on the other hand, completely sort of different. And I thought I'd pop this up to really define both. Many of you may have heard of these secondary headaches, typically stroke, subarachnoid hemorrhages, bleeds, sinus thrombosis, meningitis. You know, need I go on? But it's just really to sort of emphasize that these headaches are caused by other things, whereas primary headaches are not. So primary headaches, if you want some bedtime reading, which I'm sure if you did start it, you won't get very far, you'd fall asleep. It's quite heavy. I'm not trying to put you off, but it is very heavy, is the classification of headaches, the International Headache Society. And it's kind of like our Bible, really. It's kind of our diagnostic criteria. And the red box indicates the main primary headaches that we deal with in clinic. So for the benefit, if you, it's quite small, that writing. So migraine, number one, tension type headache, trigeminal autonomic cephalalgias, which are very painful headaches, PACs in other words, and that can include cluster headache and other primary headache disorders. But like I say, this is just a whistle-stop tour, so it's just giving you an overview. So I thought I would try and define a few of these primary headache disorders, because they can be entangled and kind of get in the mix with migraine. So tension type headache can be commonly seen in clinic, and it is described as a tight band and like a squeezing of the head, usually mild to moderate. But the key thing with this headache, it's featureless. And when we say featureless, it just means that you don't usually get any vomiting, light sensitive. It's that type of headache you get maybe at the end of the day, a really hard working day, too much laptop screen time type of headache. It's still not very well understood, but it does tend to be triggered by stress. It doesn't tend to significantly impact one's life. It's typically short-lived. And like I just said, stress and tiredness, big triggers. Episodes are not as frequent, but you need to be careful regarding painkillers, because that can lead to an increase in headache. Not sure if many of you are aware of cluster headache. Well, it says it all, really. Excruciating pain is probably an understatement. It's also known as suicide headache, because the patient suffering them just want to do that, or cause pain in another part of the body just to get rid of the pain. Typically, these are your characteristics: once seen, never forgotten, one-sided, always one-sided, nasal blockage, eye tearing, lasts about 15 minutes, 3 hours. Very restless and agitated. And with this headache, the last thing the patient wants to do is lie down. It's the last thing, so you know that this is definitely cluster. Like I just said, suicide headache, once seen, never forgotten. And then we come on to migraine, which is going to be the basis of this talk, really. So migraine, well, it comes in all formats, but typically throbbing pain, intense, can be one-sided, but can be the whole head, usually the whole head. Nausea, vomiting, light sensitivity, noise sensitivity, vomiting, yes, you name it. And the duration can last for days. Associated with that, you don't only just have the pain, but you've got lethargy, brain fog, poor concentration. And, you know, this is all prior to the headache. Sometimes people feel like they're having mood changes, cravings, dizziness. So, you know, it's not just a headache, which many people think. And like I said, the stigma around this and why it's poorly understood is migraine has always sort of been sort of perceived as, oh, well, it's not very serious, is it? It's just a headache. So the impact, well, astonishingly, 12% of the population suffer from this. 1 to 2% suffer chronic migraine, and that's having headache more than 15 days per month. 4.4% per year consult GPs for headache. And as mentioned at the start, sickness, absence from work, 20%. And at least, and probably more, but at least 33% of all neurology referrals include some kind of migraine, headache, or primary headache. Just very briefly, just to sort of, there is a somewhat, arbitrary split with episodic versus chronic migraine. Doesn't mean to say they're any worse than each, that in fact, episodic migraine is having less than 15 days of headache, but those days that you are having headache could be debilitating. They could just see you off for the whole day. So either way, they're both as debilitating as each other. Chronic migraine just typically means there's a headache there every day, some sort of headache every single day. Migraine and hormones. Hormones affect migraine or absolutely massively. Menstrual migraine which occurs within 2 days prior to a period or in the first 3 days of the actual period and at no other time during the month. That's specifically menstrual migraine. Rest of the time, absolutely fine. And it's most commonly with aura, which we'll come on to. With aura, there's an increased risk of ischemic stroke, and it's especially risky or higher risk in those women who use combined hormonal contraception. So I'd always advise progesterone-only contraception in that case. Menstrual-related migraine is migraine without aura, and that occurs more frequently during the time of the period or pre-period, but it can also occur around the times or other times of the menstrual cycle. Quite complex, but what really helps is a headache diary. You present if you work in primary care, if you work in secondary care, wherever your clinics are, headache diary. Someone presents with headache, start a diary. It's the only way you can get an accurate account. Hemiplegic migraine is often very frightening for patients. Quite often, patients feel that they're having a stroke, and they're quite shocked to be told that no, this is migraine. And hemiplegic migraine is a gradual sort of feeling. Different with a stroke is it's very slow, and patients often complain with tingles, pins and needles, bit of facial droop, slurred speech, and it's a very, very gradual process and very weakness in one side, usually left, so left or right, hemiplegic meaning half weakness, and it's always accompanied then by the headaches. Seeing this more commonly now, and thankfully we're able to treat it a little better. This is probably one of the most common cases in a clinic, medication overuse, headache. So it starts off with the medication overuse, and again in this criteria. So people may have an underlying migraine disorder, and it could be something like 4 days a month. So but for those 4 days a month, they might turn to something like ibuprofen, paracetamol, and then they'll have a little bit more headaches, so ibuprofen, paracetamol. Before you know it, it's being taken on a daily basis. Even if it's one dose, it doesn't matter, it's daily. And the brain becomes very desensitized to these treatments. And before you know it, it wants more of it. The brain wants more, and you can't give it any more. And this is what's called medication overuse. And then you end up with this relentless headache that will never go, no matter how many painkillers you take. The crux of this is you need to treat the medication overuse headache. You need to treat the medication overuse, before treating the headache. And it's usually meaning going cold turkey with painkillers. It's horrible, but we have to do it. And usually, believe it or not, patients get better just by stopping the treatments. I've seen it happen, but it's a good one. Headache diary, yeah. If you take anything from today, it's the headache diary. It's not only it's a tool that empowers the patient. And when I say that, it's, you know, patients lose control when they have headache. They feel that their lives are completely, you know, social life, personal life, everything, work life. So it's a bit of control and managing the condition. It does definitely help us firm a diagnosis, and you're able to recognise triggers, and also we can monitor treatments and whether they're effective or not. Sorry, went too fast then. Assess whether treatments are effective or not. A headache diary is very, very useful, and it can be electronic. I often, people can use their phones, whatever helps, whatever's easiest for them to record them. So moving very briefly with treatments, again, this could be a session in itself. So the main oral preventatives for migraine, the ones highlighted, propranolol, amitriptyline, topiramate, remain to be the 3 gold standard treatments. They have the biggest evidence base, and they've been demonstrated in big clinical trials to be very, very effective in migraine for both episodic migraine and chronic migraine. The others around that, they're slightly less, the evidence is a little weaker. Pizotifen, for example, very, very old sort of historical drug, still used, can be effective, but, you know, as time moves on, they start going down the chain, as it were. There's one there, flunarizine, that's that's excellent treatment, but only available in certain secondary care centres. But that's sort of the oral treatments in a nutshell of good evidence. The rule to preventatives is always start low and go very slow. You don't ever start treatments at a very high dose. The brain has been so used to being in this cycle of pain, it needs time to get used to, you know, recognizing there's a new treatment on board. And we do say give 3 months, because like I say, you know, patients have had chronic migraine for years and years and years. So you need time for the treatments to work. It doesn't work after 1 dose. And that takes a lot of support from us as clinicians to really try and get the patients to persevere. It's very difficult. Acute treatments very quickly, aspirin, 900 milligram dose works excellent in especially in hemiplegic migraine attacks, I would say, but any migraine attacks. Antiemetics, of course, triptans, sumatriptan, very commonly used, but again, beware of overuse, so no more than sort of 6 doses in a month, I would say. I thought I'd put a few information from the USA. There are new treatments of acute treatments on the horizon, as you can see, and dietins at the end there, they may be a good substitute for triptans due to the so with triptans there is a likelihood of cardiac problems, whereas dietans may not. But like I say, there's sort of a future treatment. Injectables, many of you may have heard Botox treatment, and no, I'm not improving people's wrinkles in this case, but it's very, very effective for pain management, and that involves 31 injections around the forehead, temporal areas, back of the head, and trapezius areas. Very commonly used now. It's been around for about 12 years, 13 years for migraine, and that's for chronic migraine. So that's very effective. We do provide the greater occipital nerve block, again, a very common and popular treatment, very effective. This works in a slightly different way by using lidocaine and steroid to numb the head initially, which essentially switches off your pain receptors. Can very, very effective. Then the new kids on the block, the new drugs, the anti-CGRP monoclonal antibody drugs. So these work by lowering or blocking a peptide that 30 years of research has found that those who have migraine have higher levels of this peptide. This rises peptide, and what this treatment does is block it essentially. It's the ones we have at the minute are self-administered monthly injections. Again, very, very, very effective. But then, you know, like all preventatives, what works for one may not work for another. I see this a lot. Still lots of research going into these, and there's even more about to come on the market as well. And we can't forget treatment. We can't forget lifestyle when we talk about treatment. Caffeine, as we've mentioned, medication overuse, stress, sleep, priority, absolute number one treatment, sleep. I know that's hard for some people. Exercise, and yes, monitoring the alcohol as well. But now this, you know, I always say 50% lifestyle, 50% treatment. So do remember that headache is a common problem. Primary care clinicians do see a clear majority of headaches, and quite often can be pressured by patients for scans. And you know, must remember, when if you're pretty certain it's migraine, there's no need to scan, and scanning can obviously open the doors to other unrelated findings or incidental findings, which opens another sort of can of worms. And yeah, primary headaches, they're very, very disabling, very severe, but they just don't require scanning. And if you were concerned about a tumour, astonishingly, only 1% have a headache as the sole symptom. It's very, very, yes, you can get headache, but it's not usually the first symptom of a tumour. This is just a reference. This is a Northern Adult Management Guideline. And again, I know you won't be able to see this very clearly, but I think this is a fantastic tool to manage someone in clinic. Very easy to follow, and it just lets you be aware of any red flags, you know, giant cell arteritis, you know, considering CT scans. But I'll leave my contact details at the end, just to, you know, if you want any information on that. And then just a sort of example of my sort of role within the headache clinic. And as you can see, I do accept referrals, advice and guidance from neurology triage. I also am very fortunate to have a pharmacist on board within my team who is fantastic at doing reviews of our new treatments, which is a brilliant addition to the team. We're looking at having access to rapid access clinics, and also looking ahead, we're hoping to have a nurse-led LP service, and I also do refer for MRI, organise my own scans and things. So that's and also refer patients for injectables, and education, and other treatments. So finally, just a few resources there for you. I would recommend the Migraine Trust, fantastic resource, nice guidelines, of course, and that is me. Should anyone want to contact me, or feel free, if you would like to sit in one of my clinics, I'd be happy to accommodate. I think I always love teaching people about headache, and especially migraine and primary headaches. So I think just been watching the time. Yes, I think that's it. I hope it's been useful for you.
That's great. Thanks very much, Siobhan. That's really been very useful. Clearly something that's very prevalent across the population. Some great insight there, and some really good advice as well. We don't have any questions in the chat, but does anyone have any questions that they'd like to pose to Siobhan now? Please feel free to take your mic off mute, pop your camera on. Jeanette, you've got your hand up.
Hi Siobhan.
Hello.
A couple of years ago, I went to Dr. Van der Poel's headache forum, and I remember her saying something about migrainous type headaches. So headaches that aren't quite a full-on migraine, but they have one feature that might mean they're sort of more migrainous.
Yeah, I understand where you're coming from. Do you mean so it's not migraine, but it's a headache that has migraine features?
Yeah. So it could be it could be more like a tension headache, but I think she said it would have one other feature, like you might feel a bit nauseous or
yeah. I mean, this is it. It's never cut and dried. I mean, an example of that, I would, as you were talking then, for example, post-traumatic headaches or post-surgical headaches, for example. Now, there's nothing, it doesn't say migraine in that at all, but what you will find is they can demonstrate features of migraine, such as the throbbing sensation, the light sensitivity, noise, the need to lie down with it. And although it isn't, well, in a sense, migraine, you'll find that the migraine features are there, and that's why we tend to treat those with migraine preventatives. It's like the tension type headache. Tension type usually doesn't have any features. But however, it is like a tight band, but it's featureless, as in you don't feel sick with it and things like that. But yeah, I think it, like I said, there's never there can't be a fine line, but if you're having at least one or two of those features, like nausea, vomiting, light sensitivity, then it would probably be veering towards a migraine headache, and that's how you treat it. That helps.
Yeah, thank you.
Thanks for that. And we have another question in the chat from Jenny. She firstly says, thanks so much, Siobhan. As a frequent migraine sufferer, I really appreciate this information. And she's asking, is it possible to refer directly to your service, or does it need to come from a GP?
Yes, I think in the first instance it would be GP, but now I exist, which is this is part of it. Then this shouldn't be. I mean, if the GP is confident in refering, some GP is quite confident to be able to prescribe first line treatments. Don't get me wrong, but if you don't feel that that's the case, or you've been suffering them for many, many, many years, you obviously need a specialist input who actually does specialize in that. So yeah, that would be my advice.
Thank you.
And okay, I don't think we have any more. We don't have any more hands up, and we don't seem to have anything else in. Oh, hang on, sorry. Debbie Archer's just asking, hi Siobhan, did you mention the side effects from sumatriptan affecting the heart? What symptoms would these be, please?
Yeah, good question. So sumatriptan can so you'd only take so many a month, 6 a month, very minimum. And yes, it can cause hot flushes. It can cause quite a what kind of wipe you out. That's what people say. It wipes me out. And it can cause chest pain in some people, a bit of chest pain, bit of cardiac sort of, you feel a bit ill with it. This is like quite, if you're getting it quite severe. If you do get any of those symptoms, and it does say that you can get them, you don't take any more. You simply don't take any more of that, because there are other acute treatments out there. It can raise high blood pressure as well. So if you were taking it, you have to be taking it quite regular to kind of get these symptoms. However, some people are very sensitive to it, and even one dose they can feel rather ill. So anything like that, just stop it, because there's plenty of other things.
That's great. Thanks very much. So as Siobhan said, do get in touch if you have any further questions, if you want to find out some more. And the offer of job shadowing or going to see the clinics in action is really great. I would really support that. So thanks very much. We are running out of time, but there is a quick evaluation form in the chat. If you could give us some feedback, that would be really great. And if Siobhan, you could just move on to the next slide. If anyone has any suggestions for future lunch and learns, or if you know anyone who would like to present, please get in touch with the CLIC, and the email address is up there. The next Lunch and Learn will be on the 18th of May, and it's being delivered by Anne Forrest and is about staff retention and the NHS People Promise. So thanks again for your time today. Thank you very much, Siobhan, for a super presentation, and we will be back again on the 18th of May. Thanks a lot. Bye-bye.
Thanks, everyone. Bye-bye.